when I moved down to this little village that's about 20 minutes from here called Corrales, I needed a new doctor for me and the kids, and I met her, and it's the coolest little practice nestled in between ranches, and Corrales still has all these llamas and goats and chickens, and so you kind of are going, okay, is this a medical office or is this a veterinary office? And Alyson started this clinic. She, I don't want to ask her age, but she got her medical school degree, raising 6 children, started later in life, and she got thrown into this whole world, and I'll let her tell the story. But I've come to learn that in all situations, but especially with what's going on with transverse myelitis and MS and all these illnesses, learn to trust, and if you don't trust, find a primary care physician that you do trust. So Alyson, Thal from Corrales Family Practice. My new big sister.
Hello, and thank you, Shelley, and especially thank you, the Unser family, the gang. I won't go through each individual. Unlike most of the speakers that you've heard the past couple of days, this is not my area of expertise. I'm a family doc. I'm a mother of 6, and I'm here to sort of tell a story about my relationship with the Unsers, as well as many other patients. This first slide really looks at the big picture, and besides Cody and the Unser family, I want you to know that in preparation for this talk, I called my MS patients, some of whom may be here, and I only have one TM patient, and I'd already spoken to her, and I asked them, what do I do for you? What's my role? Because I'm going to be speaking with a bunch of really esteemed specialists, and I feel really out of place, and I need to know that I do something for you, that I can relate to this group. And so my talk today is really based on the feedback I received from my patients. And I also really want to thank my father. My father was actually at Johns Hopkins in 1951. He was on the Blue Baby team with Dr. Alfred Blaylock. My father is a trauma surgeon, was on the first cardiac transplant team in this country. And my father was deaf through medical school, came to this country as an immigrant during World War II. And he is my inspiration. He also went back to Johns Hopkins in 1970 as visiting professor of surgery. So in some strange way, Cody has brought me back to my father's roots. And thank you to, and my father also made it very clear that you don't speak about Johns Hopkins, you speak about the Johns Hopkins. And he made it very clear that I have to put that the in or I'll get in trouble. Okay. I'm from a ranch in northern New Mexico. I'm a cowgirl, and I'm a big picture girl. I've spent a lot of time in the dirt, falling off of horses, and I suspect that one of the other reasons that I'm interested in giving this talk is I actually did sustain a spinal cord injury. 20 years ago, I was bucked off a horse. I had one of my sons with me, and I'm used to falling off of horses, but usually I have my arms to balance me. I had one of my sons with me. He was 1.5 years old, and I held on to him when I got bucked off, and I broke my back, and I was paralyzed for 3 months. I don't think Cody or any of the Unsers knew this, but I sat on the 7th floor of the old St. Joe's in rehab for 3 months, unable to walk, watching I-25 traffic, wishing I was in it. If that's not depression, I don't know what is. So why me? Besides my magnanimous personality and my lack of multiple journal articles, and that experience, I also would like to say that I've been a primary care doctor for 25 years. I've got 4 generations of families now. I also, when I first started the practice, I used to work for all the major health plans in the city. And About 9 years ago, I got a little fed up. I got fed up with the way I was practicing medicine, and I realized that I wanted to deliver a different product. And so in order to do that and support 6 kids, I had to work some part-time work. So I worked as an emergency room doctor for 4 years while I built the practice. And so I speak to you not just as a primary care, but also as an emergency room doctor, that and I am not a board certified ER doc, but I did do a fair share of it, and I saw the presentation of paralysis and some of the descriptions that you've heard so far. I saw that in the acute setting as well as in the chronic setting as a primary care. Actually, I'm sorry, I've got one other concept here, forgive me. The Johns Hopkins staff, welcome to the land of the big sky. And for purposes of this talk, focusing on the big picture. Beauty is in the whole and in the parts. And this picture is beautiful. It's northern New Mexico. And I want to take you through when a new patient comes into my practice and how I approach it, whether it's an MS patient, whether it's a TM patient, whether it's a COPD, a diabetic, you know, chronic disease from the primary care point of view, chronic disease is the issue. And the question is, rare disorders like TM and MS are part of the picture, but for the primary care, the average primary care is terrified of these diseases. Why? Because of all these wonderful speakers that you've heard and their expertise. How in the heck can we know what they know? We can't. And so we feel very inadequate. And as a result, we rely on our patients to teach us. And the Unser family, and in particular Cody, and my MS patients have taught me how to be a better doctor. When a patient first comes into my practice, I schedule a 30-minute visit. I give them, and I wasn't able to duplicate this, but this is my card, and on it has 3 puzzle pieces coming together. And I tell every patient, at the end of this 30-minute visit, you will know whether I'm the right doctor for you. And I will know whether you're the right patient for me. And I say, number 1, do you have a sense of humor? Because we're both going to need it to go through this journey. I show them this puzzle, and I tell them I've got 24-piece puzzles, and I've got 1,000-piece puzzles in this practice. And I never know what you are until we sit down and talk. And so what we do is we talk. And I give out what's called a homework sheet, because patients forget everything the doctor says. I have a 75-year-old wonderful lady, patient of mine for many years, that puts a pretty picture depending on the season. So we've got Santa Clauses and Easter bunnies and beautiful mountain scenes, and the patients love these things, and they tell a story. It's a diary of their care. And I'm not trying to divert from MS and TM, but I'm hoping at the end of this talk that you will see, when you go to your primary care, what we're facing and help us. Because it's not just the specialists helping us, it's the patients helping us. I go through an example of my mother. My mother has a cardiologist, a pulmonologist, a gastroenterologist, a dermatologist, a gynecologist, an acupuncturist, a physiatrist, who is a chronic pain specialist, and a hairdresser. And the one that knows the most about her, of course, is the hairdresser. Now, everybody thinks that's humorous, and I do too, or I wouldn't tell the story, but it's actually tragic. It's tragic that the richest country in the world cannot communicate better with one another, and our parts, that the bigger picture is broken. And I am pleading to you as a group that's very focused on 1 or 2 disease states to see this as an opportunity to do it right. This is a small percentage of chronic disease, but if we could do it right in this group, we could take it to other disease states. And I see this as such a tremendous opportunity for that. When a patient comes in, then I tell them, look, all these specialists of yours are wonderful, I need them, they're brilliant, but you know what, if they don't communicate with me, and I show them this picture, what happens is people fall through the cracks. I tell them I was going to put on my card, let me be your crack filler-upper. Let me fill in your cracks, okay? Didn't create a pretty visual. So I decided to integrate the pieces of your puzzle. And that is what I have on my card, and that is what I'm dedicated to. And the concept here with this specific disease state is really more an example of what we really need to do on a bigger picture. And I would urge you, because a lot of you that have TM or MS or any other chronic disease, you know how complicated it gets, and you get frustrated when you go into your doctor and not all the pieces are there. But you can help, and that's part of my plea. All right, now I think I'm ready for the next slide. The next concept is the patient as a wheel. And on the bottom, actually, I guess it's on the top, thanks to Dr. Morrison. The patient is a wheel, and you as patients are moving through life at your own speed in your own direction. But those of you with chronic disease, in this case TM and MS, you have multiple different players. And if those players are not coordinated, your wheel could be in jeopardy. I want to pay special attention to the 12 o'clock circle, the family. Not all primary care doctors, of course, are family doctors. And I do want to distinguish that, because part of the strength of me, I believe, being a good doctor is not just being Cody's doctor, but being Shelley's doctor, being Shannon's doctor, being Jody's doctor, being Grandma Colette's doctor. Part of my strength in helping Cody is being a part of that family and understanding what it did to each one of those members. And you know, I spent a year at the Cancer Center here at UNM back in the early 80s with a wonderful physician named Dr. Jack Psyche, who many of you locally will know. And he taught me two things about cancer patients, which I actually apply to any chronic disease. He said, Alyson, when you see one of these patients, urge them to take one day at a time, one day at a time. They will drive themselves crazy if they think too far forward and project. Number two, pay value to the spouse or significant other. What happens is anybody with chronic disease often has a significant other who it often is harder on that significant other. All the focus is on the patient. But I'm struck by the strength of spouses and significant others, in this case parents of Cody and siblings. And you know, we tend to protect the patient as family. And I remember Dr. Psyche saying, look, the cancer patient goes in the bathroom and cries about being scared of dying. And the spouse goes in the bathroom and cries about losing their spouse. But neither one want to talk to each other about it because they don't want to hurt the other one. They don't want to scare the other one. And so by protecting each other, they often hurt each other. And so I explore that as a primary care doctor. The 1 o'clock position is, of course, the role of the community neurologist, in this case for MS, TM, various other neurologic disorders. I do very much value our community neurologists. I will give a brief example. Doug Barrett, are you still here? He was here. Must have left when he saw me get up. Doug is a community neurologist. And I invited Doug to my office about 2 or 3 years ago when I noticed that a lot of my MS patients' husbands were depressed. I mean, I just couldn't get, and these are young couples, you know, and I noticed that the husbands in particular were just, when I do their physical, they wouldn't come in specially and say I'm depressed, but you know how men are. You got to kind of read between the lines a little sometimes. No offense, guys. But anyway, and you know, so I called Doug Barrett and I said, Doug, I'm worried about my MS patients' spouses. Could we a meeting in my office? So I got a drug rep to bring a dinner, and we sponsored a dinner in my office one evening for about 10 couples. And it was amazing. I learned so much. And all these guys, you know, there's all these support groups in the newspaper, but the average couple suffering from a disease like this doesn't want to go to those support groups, or they've done it and they don't want to go there again. It's kind of like dieting, you know. After a while, you just don't want to join Weight Watchers again. I mean, it's the same thing. And so this group came to my office, about 20 of them, and they sat around in my waiting room, which is kind of, as Shelley mentioned, it's a refurbished old broken house that I fixed up. And so it looks like a living room. And we sat there and ate and shared. And it was incredible. And I learned probably more than the rest of them. And so I want to pay tribute to our community neurologists. The experimental protocols at 2 o'clock, would bring up things like the Johns Hopkins group. Of course, these groups are incredibly important, but check out the wheel. This is only part of the spokes. I mean, this patient, if information doesn't come back to the family doctor, when that patient walks in sick, we don't have a clue. I mean, it's overwhelming, and we often do the wrong thing because we don't know what else to do, and we can't find some of the specialists. Slide 4, communication is really the buzzword. Everybody talks about it, but very few of us really do it. I don't know why. I don't know why. It must be the pace of our society, but I want to recall for you the lady that was here yesterday that asked a question in the audience. I think she was a patient. When somebody from the Johns Hopkins group was lecturing about all these wonderful protocols and information, she asked a question, will my doctor know how to get onto this? Will my doctor get this information? That's the key, because not everybody can get to Johns Hopkins, the Johns Hopkins. And so I was really, whoever that lady was, I really value your question, because that's the challenge, is how do we, family docs, internists, pediatricians, primary care folks, how do we get into this wonderful research and wonderful opportunities for those of you that suffer from chronic disease? When the wheel works, it's a beautiful, free, flowing thing. But when it doesn't work, it's like a gear on a bicycle. When that chain falls off, it's not a fun ride. And that's unfortunately what happens a lot. It's noisy and it can be dangerous. The goal, to take the model of the Johns Hopkins group, the integrated team, and extrapolate it for the rest of us into the real world. And real meaning out there where people live and go to school and all the rest of it. Not to belabor this concept, but when specialists then refer to specialists who then refer to more specialists, you have multiple wheels with no focal point. Should the specialist be the primary? You know, sometimes I ask myself that. I ask myself that not just in the case of TM and MS, but in chronic diabetics, my COPD patients, all my chronic disease states, my post-heart attack patients, my cancer patients. Do I even have a role for these people, or am I just one more hindrance for them? I don't know the answer. I obviously believe that my role is important, but sometimes I wonder, maybe I shouldn't be the primary. Maybe this is just too complicated. Other models exist like this already in the case of heart disease, diabetic care, severe rheumatologic disorders, where there are, in fact, models about no primary care, that the rheumatologist and the endocrinologist is the primary. And as medicine evolves over the next 5 or 10 years, primary care doctors like myself will be going away. We are being phased out by minute clinics. You will have minute clinics in your malls if you don't already. And the value of the internal relationship between a primary care is not particularly valued in that model. In some cases, it may not be a bad thing. Go in for your sore throat, that sort of thing. But I guess I'm still a believer of the old-fashioned way. Slide 6. Pretty self-explanatory. I'm sorry, there may be 1 or 2 slides that are a little bit out of order here. Making the correct diagnosis, again, as an ER doc, that's which I've played, where I've seen presentations, acute, brand new presentations of MS present. Of course, we can't come up with the diagnosis right away, but we can start the process. Getting feedback from specialists. Pretty much the rest of this is something that I've gone over, so I won't belabor it. Making the correct diagnosis. Esther, are you here? I want to pay special tribute to one of my MS patients, Esther, who just waved. As I told you, I called many of my patients, including Esther, but in preparation of this talk. And I want to share with you a little bit of what she shared with me. When Esther first presented with her MS, she presented a little atypically. And forgive me if I'm not quite correct on all of this, Esther. She presented with vomiting and weight loss. And to cut to the chase, the bottom line was they thought she was a psych case. They thought she was bulimic. They wanted to put her in a psych hospital. They couldn't figure out why she couldn't stop vomiting. Another example of something that she shared with me is that when she gets pain, and we just had a wonderful talk on pain, but when she gets pain, everybody thinks it's got to be her MS pain. Well, you know, there's other pain. These are real live people with other, I mean, she's a middle-aged woman like myself with middle-aged issues. And not everything she gets is related to her MS. And so she went into an urgent care, I believe, and said that her face hurt. And they wanted to put her on steroids and did put her on steroids. And of course, she ended up with, she had a tooth abscess all along. But you know, we don't think of that. We think, oh my God, it's got to be their MS. And so yes, it may be, but I think it's very important, especially in the ER and urgent care setting where most of those doctors don't have a clue about the patient, is to avoid having our patients with these chronic disabilities even showing up in the urgent care and emergency room. It's a failure in primary care access that this happens. And it was another MS patient of mine many years ago that was actually going blind and had no insurance that really taught me, along with Esther, how to do IV solumedrol in my office and spare the patient from going to the ER. And so now when any of my MS patients flare, I get them right in, we get them on their IVs, and we avoid the ER and urgent care visit if we can. The third point is, what's written at the bottom is, Doc, it's not my MS. I know the difference. We need to learn to listen to our patients. They know. They may not always be right, but you know what? We got to listen. Of course, no lecture here would be complete without a tribute to my wonderful little girl who has taught me to be a better doctor. And although TM is not exactly the mainstay of my practice, I can tell you, working with Cody, watching her grow up, again, same issues. Cody was not just a 12-year-old TM patient. Cody was a 12-year-old girl who had TM. And I needed to help her grow up as a young girl and a young woman and help her feel comfortable with herself and deal with the issues of young girls. And so, you know, she's not just the disease. And she is obviously a tribute to that. I should say no more about that. I will be harping on the concept that the beauty is in the parts and in the whole. The parts meaning the specialists, how important they are. The rainbow's beauty is a combination of the parts. But the big picture is also a beautiful thing to behold. And this is northern New Mexico at our ranch. Some issues for primary care is getting down to actually what I'm supposed to talk about here. I don't want you thinking I'm getting too poetic on you. What happens to us? Well, you know, one of my MS patients will walk in and I will be loaded with all this stuff from home health. I will have questions about wheelchair specifics. You think I know much about wheelchairs? No, I don't. I'll be asked about different kinds of diapers and bladder and bowel. You know what? I don't know about that. Teach me. I want to learn. I want to make it easier for my patients. Exercise programs, we're going to hear more about that, and we've heard some. I don't know how, you know, my patients look to me because for whatever reason they may have heard it from many of you as specialists, but number one, they don't remember. Number two, they can't find you easily. And three, they think I'm supposed to know everything, which of course I don't. Side effects of drugs and treatments. Again, after this talk and being aware of some of the available websites, which I didn't know before, I think I can do a little better job, but realize that many of these patients have multiple diseases. I treat their blood pressure, I treat their diabetes, I treat their reflux, I treat their menopause, I treat all that stuff, and I have no clue what new study drug you may have them on and whether I should even be changing any of that. And if they've got diarrhea or a headache, could that be from your drug or mine? And to try to get you on the phone in the middle of your busy day does not seem like the most efficient way to handle things. Immunizations, a huge controversy. Many people believe that sometimes childhood immunizations could be suspicious for inducing some of these diseases. Obviously, the verdict's not out. I haven't heard a lot about that in this lecture, but I can tell you that every time we hit our flu season and my MS patients come in, or Cody, or any of the other neurologic patients that may have an immunologic base or chronic disease in other disease states, my question is always, should I give them a flu shot? I mean, we have the worst flu season on record. We're still peaking from our flu season here because of the moisture we finally got. And, I don't know. And for me to sit on the phone and bother you, the specialists, where are the guidelines? And, there are so many websites out there. I can't access all of them. I want to keep it short and sweet. And I want to be able, when Cody walks in, to be able to look up from her specialist to say, look, if she needs this, this, and this is what we would recommend. And not have to bother my specialty colleagues. More issues. I've discussed some of these. Birth control. We heard about this a little bit yesterday with the wonderful woman who actually had Donna, I believe was her name, who's an OBGYN nurse and also got TM transiently. Birth control. Yeah, they sit in a wheelchair, and yeah, they're at increased risk for clot if they go on birth control pills. But you know what? They don't want to get pregnant either, so let's talk. What are our options? And I'd like to be able to talk to somebody about those issues. We already heard from Dr. Taylor about the role of supplements and dietary issues. I have no clue. I mean, most of us in traditional medicine are not particularly good at this issue. But, when patients get frustrated with us in traditional medicine, when they see themselves falling through the cracks, they will go to somebody that'll listen. And it doesn't really matter whether it works or not, because they believe it works, and perception is reality. And we all know that. Guidance, of course, is critical. I've sort of spoken about this and spoken about the meeting of the local neurologist that came to my office and helped me. I really want to have a tribute also to the families of patients with chronic disease, whether it's TM, MS, or any chronic disease. You are the unsung heroes. And I value you, and I also value, as a family doctor, your input about your significant other or child. Because sometimes the patient won't tell the doctor, but the husband or the kid or the grandmother, I get behind closed doors that way, and I think I'm a better doctor. I really have this slide for the Johns Hopkins group and the local specialists from Kerry Tingley and the university in particular. You are the experts, and I value you, and I have total respect for your knowledge base. But either train us, make it easy. When you send that note back to me, give me guidance. Don't just tell me about what the blood pressure and the this and that. If you're going to send me a note, send me something so that I can be really good for that patient that we're sharing. The patients can't find you. The patients can't find, and it may not be appropriate for them to find you, but they come and they find me and other primary care doctors like me. We look to you to guide us, and I really believe this is an opportunity with this disease state to do that. Oops. Brainstorming the solution. I wish, and I would be more than willing to help any specialty group that might want to construe a flow sheet, just like we have for diabetes, COPD, all the chronic disease management. I have an MBA. Years ago, I went back to business school, and I took whatever kid I was breastfeeding at the time back with me at night school, and I had 6 kids in 8 years. I kind of cranked them out. I found something I did well, so I did a lot of it, but then raising them, of course, was another challenge. I thought I wanted to change the system when I worked for Loveless and Presbyterian in the university years ago. And nobody would listen to a simple-minded family practitioner unless they had a business degree. So I went back to night school, this is 10 or 12 years ago, and got a business degree. And, sort of climbed that corporate ladder. And I realized it's really shaky up there for me, and that I belong in the trenches. And I belong out there with my folks. And yeah, it's not the best way to make a lot of money, fame, fortune, but you know what? I sleep well at night, and I feel like in my tiny way I'm making a difference. I could make a bigger difference, though, if I was better connected with you, the specialists, and we could create a form, we could create a communication piece that doesn't rely on 10 different websites of expertise. Each patient brings their unique issues, and if we could learn to communicate maybe a little better, especially with electronic medical records out and so on, I think that might be helpful. I'm going to end with the northern goshawk. As I shared with you, I'm from a ranch in northern New Mexico. I wasn't actually born up there. I was born in the Midwest and did some of my university in South Africa, where I went back to sort of discover my roots. But northern New Mexico is my home. And my brother, who is a horse veterinarian, equine vet in Santa Fe, drew this picture. This is a northern goshawk, very, very typical of the northern part of this state. And I will end once again that the beauty is in the details and the big picture. I want to thank all of you for listening to me. I want to thank the Unser family, my esteemed colleagues at all the multiple universities and specialty centers, and especially to my father and my brother who inspire me. Thank you.